Welcome to the recorded version of Supporting Families Through Hospice and Palliative Care, part of the Family Caregiver Support webinar series brought to you by the American Society on Aging and a generous sponsorship from Homestead Senior Care.
Our main presenter today is going to be Lakeland Hogan. Lakeland is a caregiver advocate for Homestead Senior Care. She holds a graduate certificate in gerontology and is currently working toward a Master's of Arts in Social Gerontology. She also holds a Master's in Business Administration, and her undergraduate education focused on marketing and communication studies. Lakeland has professional experience in the private and public sectors of senior care services. She has worked on special projects for the University of Nebraska-Omaha's Department of Gerontology and the local area agency on aging. She is also active in her local chapter of the Alzheimer's Association. Lakeland has experience assisting senior clients and helping their families navigate the senior care continuum. She is passionate about helping others, especially aging adults and their families. Joining us for the Q&A session coming up later on is going to be Lenita Noki. Lenita is a registered nurse with a bachelor's in business management. Lenita is also a certified managed care nurse with a varied background in nursing encompassing direct care and clinical business. Over the past 25 years, Lenita has worked in home health and hospitals, all while diversifying her experience in the medical community. Lenita's passion and dedication to educating families, along with more than 2 decades of professional medical experience, makes her uniquely qualified in advising family caregivers with medical concerns they may have while caring for an aging loved one. And with that, I would like to turn the presentation and the floor over to our presenters. Lakeland Hogan, thank you for being here today.
Thanks so much for having us, Steve. And I'm excited to have Lenita join us here in a little bit. She'll be speaking to more of the medical aspects of hospice and palliative care, and will help us really understand the difference between the two, because I know in my experience, especially before I got into this industry, before I started studying gerontology, I myself, didn't even know palliative care existed, and then once I learned about it, it was hard for me even to distinguish the difference. So we'll dive more deeply into that here in a bit. But as you know, end of life is a time that no family looks forward to, and that's why the topic of hospice and palliative care can be a difficult one to approach. The challenges for the family caregiver might range from physical and emotional strain to mental and psychological stress. And as professionals, we can help them navigate the physical, emotional, and spiritual journey. And we have the responsibility in our daily jobs to educate families and provide them with information and support during this difficult time. So as we go through the webinar today, I know some of it might be a refresher for some of you folks on the line, but I hope that you'll end up with some new information to add to your library of resources, or maybe you'll hear something in a different way that you'll be able to better communicate to families. And then just to give a little context to the presentation, I wanted to let you know Homestead Senior Care partnered with the Canadian Hospice Palliative Care Association to develop a training for our professional caregivers and for family caregivers to educate them about end of life. So I'm going to use some of that information throughout today's presentation, and then I'm going to share their resource with you at the end. We always share a lot of great resources at the end of every slide, or presentation, pardon me. So we're going to get started by looking at our objectives on the next slide. So today's webinar, hopefully you'll walk away learning some of the myths about hospice. I think there's a lot of myths out there. I also hope that you'll be able to explain the difference between hospice and palliative care, and then understand the physical, emotional, and spiritual changes that might occur, and then be able to identify members of the hospice team and understand their roles, and then learn ways to help the family caregivers better take care of themselves. And before we hop into the myths, I just wanted to take a quick poll on who we have with us today on the webinar. So if Steve can pull that up quick for us. It's always good to know the audience we're talking to. So go ahead and choose the answer that best describes you. You can click social worker or discharge planner, nurse, other healthcare professional, a family caregiver, or if none of those work for you, you can always click other. So go ahead and click the answer that best describes you, and then we'll get the results pulled up here to see who we have on the call. All right. Okay. Looks like we have a large group of social workers and discharge planners. some other healthcare providers, and some people who don't fit any of those categories, which is completely fine. I'm just so glad that all of you are on the call today to learn more about this subject. Okay, so now that we know who's on the call, let's jump into the myths on that next slide. So there's several of them listed on the screen, and I'm going to go through each of them individually. So let's go ahead and transition to the next slide and talk about the first myth, which is hospice is a place. And I don't know about you, but I'm guessing that many of you have heard somebody say, oh, my grandma went to hospice, or my loved one needs to go on hospice, we'll have to move them out of the home. So if we transition to the next slide, we are going to debunk that myth. We're doing some myth busting here today. So that is a false myth. Hospice can take place wherever the person is or where the need exists. And actually about 80% of hospice care takes place wherever the patient lives, and we'll talk a little bit more about that. And that place is usually the patient's home. So when we're talking with families, you might get that misconception, but you can tell them, educate them on the fact that hospice is not always the place. And while even in my community we have a hospice house and some facilities that are geared specifically to hospice, it doesn't mean that somebody has to move in order to receive the services. So let's take a look at another myth on the next slide. This next common myth, I already admitted to this one earlier, that palliative care is the same as hospice care. Again, I used to believe this, or I thought that the terms were used interchangeably, but that's not necessarily the case. While palliative and hospice care share some of the same principles of comfort and support, palliative care begins at diagnosis and continues during the treatment and beyond. And unlike hospice, palliative care is not synonymous with the end-of-life care. So there are some differences, and like I mentioned, Lenita's going to dive deeper here in a little bit. But let's move on to yet another myth on the next slide. So when it comes to costs of hospice care, some people are led to believe that it's very expensive, when in fact, most people who use hospice are over 65, and they're entitled to the Medicare hospice benefit. And these benefits cover virtually all the hospice services and require little, if any, out-of-pocket costs, really. So, therefore, there are minimal financial burdens to the family when they're caring for a loved one on hospice that's able to qualify for that Medicare benefit. And for many people, if a person is on hospice at the end of life, they incur less expense than somebody who's not using hospice towards end of life. And again, Lenita's going to go more into detail about this later. But in the meantime, we're going to get to another myth on the next slide. A lot of times I hear, well, if I start hospice or palliative care more specifically, then I won't get treatment. And that is a falsehood. Palliative care is given in addition to your prescribed treatment, and treatment will continue to be provided to alleviate your symptoms and emotional issues throughout the course of treatment. So again, that's a myth. So that one has been busted. And then if we take a look at the final myth here on the next slide, for a lot of people, when they think of hospice, they think that it's only for the dying person, when in fact hospice is a family-centered concept of care, and hospice focuses as much on the grieving family as it is on the dying patient. And most hospice organizations make their grief services available to the community at large and available to the families for up to a year even after their loved one passes, which is a really neat aspect of hospice. So we talked a lot about what hospice isn't, and we've busted these myths. So let's review more about what hospice is on the next slide. So as the myths show, many families don't understand what hospice truly is. And hospice is a holistic approach that creates a unique care plan with the individual and family caregivers at the center of attention. And hospice care focuses on improving quality of life and helps people complete their life journey with comfort, dignity, and companionship. And a big focus of hospice is symptom management. And that is relief and comfort. Those are the goals for those situations where there is no definitive cure for the illness or the illness is terminal. And hospice involves individuals who might be receiving medical care, pain management, emotional and spiritual support. And like I mentioned earlier, it also offers support to the family caregiver, serving as a primary caregiver and provides that support to them. Like I said, up to a lot of times a year after the loved one has passed on. And I have that stat listed up there again. 80% of hospice care is provided in the patient's home or a family member's home and where they reside, such as an assisted living facility, nursing home, independent living facility. So while those inpatient hospice facilities do exist in a lot of communities, majority of it is taking place at the person's home or in a residential living situation. So I'm going to pass it over to Anita to dive a little deeper on hospice and palliative care as we transition to the next slide.
Hello, everybody. So hospice and palliative care, when we talk about palliative care, it can best be described as pain relieving or comfort care. This approach was designed to ease suffering and improve the quality of life for patients with any debilitating illness. People of any age can receive palliative care for a serious illness or an accident, whether it's life-threatening, chronic condition, or a life-limiting illness. The goal of palliative care is to improve the symptoms, thereby helping to relieve the pain and the stress of these conditions. And as you can see on the slide, palliative care has a lot of the same focus areas as hospice, but it is not the same. As the last bullet indicates, hospice begins when that person is no longer receiving curative treatment. So the main difference is that palliative care can be used in conjunction with curative care, in other words, to cure the disease or prolong life. So people that are still getting chemotherapy or radiation would use palliative care, and then when we look at hospice care, it does not use any curative care. Another difference is that Medicare does not recognize the term palliative care, so many feel that palliative care is not a covered cost on Medicare. However, if you have Part B Medicare, many of the services needed and billed in a palliative care environment are covered. It's just not billed using the word palliative care. To highlight the difference between palliative care and hospice care, I want to take you through a story. So Mary's 80-year-old mother, Fran, who hadn't been feeling well for weeks, she made a trip to her family doctor and had a series of tests which pointed to an infected gallbladder. However, when the doctors performed the surgery to remove the gallbladder, they made another significant discovery. Surgeons found widespread cancer and removed, of course, as much as they could. After the surgery, they gave Fran and her family the bad news, and understandably, Fran wanted to do everything to try to cure the cancer. At this point in her care, Fran's goal was a cure. So Fran's doctors needed to strike a balance between the comfort and steps to help achieve that cure. So steps to help achieve that cure included hospitalizations, tests, office visits, and interventions such as chemotherapy, surgery, and radiation. All of these approaches are considered curative and palliative. 4 months later, Fran's medical team concluded that further intervention had little to no chance of curing her cancer. Fran had reached what we refer to as the tipping point, where the burdens of this approach outweighed any benefits. At this point, it made sense to Fran and her family to change their focus from curative to an entirely comfort approach, with the goal of maximizing the quality and well-being of her remaining time. They were now ready to discuss the hospice philosophy. So by using this story, it might be easier, or a similar story even, it might be easier to explain this to families. So moving on to the next slide, let's look at common medical conditions that are associated with hospice. When people think about hospice, cancer is generally the first thing that comes to mind. There are, however, a number of medical situations, including accidents and illnesses, that can lead a family and that patient to hospice. So let's look at some conditions other than cancer that are commonly referred to in hospice. Lung disease, chronic obstructive pulmonary disease would be the main one, so you might hear it called COPD. Heart disease, especially congestive heart failure, many of those are referred on to hospice. A life-debilitating stroke, advanced liver disease, end-stage kidney disease, advanced dementia, and many of the advanced neurological diseases such as Parkinson's, ALS, and MS. The only restriction on hospice referrals is that the patient must be deemed end-stage. There is no specific condition or disease restrictions. Again, any disease that is deemed to be in its end stage when further treatment is believed to pose more burden than benefit may be considered for a referral to hospice. I believe one of the biggest or greatest benefits of hospice is the support team of people that surrounds the patient and family. Let's look at that support system on the next slide. A team approach from hospice can help families make the most of their time together. So we'll start our discussion with the family caregiver. They, of course, are at the center of the hospice team because they are the core of what's happening in hospice. They are the primary caregivers for the patient and the center. They typically provide the majority of care for their loved ones, and those examples would be bathing, toileting, grooming, eating assistance. However, caregivers also can look to other members of the team for help and support and generally need that ongoing help and support. Outside the family ring, you'll see, of course, a physician. Their ongoing role is to manage that patient's symptoms and their pain once they've made that hospice choice. This involves regular evaluation of the comfort and the modifications of the medications to control the pain and other symptoms as they change or increase. Another key element is the nurse. The nurses check in on a routine and sometimes on-call basis to make sure that the patient is comfortable and his or her physical needs are being met. Nurses on the core hospice team also educate family members, teach personal care techniques, and other ways to help keep their loved ones comfortable. Then once a family decides to use hospice care, social workers generally provide information and help coordinate community services such as additional home care. They also work with the family to look at coverage and government benefits so they can get the most out of what's available to them. Another key person on that outside ring is the chaplain. A hospice chaplain is available to provide spiritual support to the person on hospice and his or her family members. Many times that happens in conjunction with the family's spiritual choice, such as their personal priest or minister. Many times you'll see speech or physical therapy involved on the hospice team. They're not always there, but a speech therapist can show a patient techniques to communicate with a family and their caregivers if they've had a drastic change. Physical therapists often help a hospice patient learn to move differently with a disability that's new to them, or maybe they're using a new device. Many hospices, or majority of the hospitals, have volunteers who help provide the patient with additional support and companionship. However, unfortunately, there are usually not enough of them to support all the patients that are in hospice, so they're definitely in demand. And so many times there's also a role for a professional caregiver. Generally, these caregivers are from an in-home care company and are available to help with the daily or intermittent care if the family feels they need more support, and generally the family usually does. The entire hospice team is there to support the person and their family with the physical, emotional, and spiritual needs of this next level. When a family moves to hospice, it is important to know what is covered. So on the next slide, we'll discuss the Medicare hospice benefit. As we all know, Medicare benefits can be very confusing, and the hospice benefit is no exception to that. So today I want to take a minute to highlight the main Medicare points that you should be aware of. A patient is eligible for a Medicare hospice benefit if they meet the following conditions. They have Medicare Part A, which is the hospital insurance of Medicare. The patient's physician certifies the terminal illness. The patient accepts that palliative care instead of curative care. They sign a statement choosing hospice care instead of the other Medicare-covered treatments. So the Medicare hospice benefit consists of 2 90-day benefit periods and then an unlimited number of 60-day benefit periods. However, the patient must continue to meet the eligibility criteria throughout all of those benefit periods. And for each benefit period, that patient must be certified as terminally ill. Their definition, of course, is 6 months or less to live if the illness runs its normal course. And that's the important caveat of this, is if the illness runs its normal course. So you'll see many patients that are in hospice for over a 6-month period. The initial 90-day benefit period, both the hospice medical director and the patient's attending physician must certify the patient's illness, and then for all subsequent benefit periods, the certification is only required from the medical director of the hospice. And that certification must always include a physician narrative to support life expectancy of 6 months or less, along with an attestation statement. And as a side note, as of today, nurse practitioners cannot certify these patients for their Medicare benefit. So let's talk about respite care. So Medicare considers respite care any short-term inpatient care provided only when necessary to relieve the patient, family members, or other persons caring for their individuals at the home. Respite care is only reimbursed for 5 consecutive days at a time. However, more than one respite period is allowable in a single billing period. So you could have more than one respite period in a 30-day period. Inpatient respite can only be provided in a Medicare-certified inpatient hospice facility or a contracted Medicare-certified hospital or skilled nursing facility that provides 24-hour care. And it's important to note that there is a 5% charge of the Medicare-approved amount for inpatient respite care to the family. I'm going to move on and talk about some hospice bill of rights. Medicare embedded the hospice patient bill of rights within their hospice regulations, and they include receiving effective pain and symptom management from the hospice team for conditions related to the terminal illness, involvement in developing their own hospice plan of care, the right to refuse care or treatment, the right to choose their own attending physician, the expectation of confidentiality of their clinical records, the dignity to be free from any mistreatment, neglect, or abuse, which would cover verbal, mental, sexual, or physical, and also includes misappropriation of their property. They have the right to be completely informed of the extent of the Medicare payment and information regarding the covered services under the hospice benefit, and the right to receive a scope of services information on what hospice will provide and the specific limitations on those services. All of these rights that are embedded within the regulation also mirror the rights published by the Hospice Association of America. And of course, if a patient is not covered by Medicare, the information needed will be very similar. However, you would need to check with your payer source to ensure you have the coverage specifics. Now I would like to transition back to Lakeland to discuss some details around the role of a professional caregiver and how they work within the hospice team.
That was great information, Lenita. And one thing that stuck out to me when you're talking about the Bill of Rights was that the family has the right to know as to what is covered in terms of their hospice benefit and what is not. And what I've found in my experience is that families automatically assume that when their loved one is receiving hospice care, that means hospice will be there 24/7, 365. And we know that that's generally not the case. Of course, hospice will come in several times a week. There'll be probably some nurse visits, maybe a bath aide, the hospice volunteer. But again, they're not providing that 24/7 care. So that falls to the family, which can be overwhelming and difficult for the family to manage, especially if they're working full-time or if there's a limited number of family members that live in town or live near the loved one. So while these hospice services provide much-needed support to the hospice patients, the life of the family caregiver often will include tasks such as providing personal care for the loved one and possibly even preparing meals, doing the housekeeping, running errands for them, that sort of thing. And as I mentioned, that can add some added stress to the life of those family caregivers. And while professional caregiver support is typically funded by private pay, just a few hours or a day or a week could mean so much to the hospice patient and their families. And professional caregivers can assist between visits from the hospice team, and they can help family members by providing those personal cares, helping with the toileting needs, with the bathing needs, and also offering some companionship, talking to them, and some light housekeeping, meal preparation. They can also help run some errands, take care of some things around the house. And I wanted to share one example. This one has stuck out in my mind for years. I was working with a family. It was a wife, and she was taking care of her husband on hospice. And someone had mentioned that she should get some outside help, some respite. So I went to meet with her, talk about it, and she said, okay, so when somebody comes in, that means I can take a bath or read a book or have lunch with my girlfriends. And I explained to her, absolutely, we're coming in to provide a little respite. And she was almost brought to tears. She was so relieved just to have a few extra hours of respite so she could recharge. So that's another resource that we can offer families when we're talking to them about the support that they'll need throughout this process. If possible, they could hire some extra help or find an organization, maybe some extra volunteers at their church, to provide a little extra respite and support for the family. Because as Lenita said, to qualify for hospice, you just have to have a terminal diagnosis or be in the end stage of an illness. So it could be anywhere from several days to months that this type of care will be needed. So the family can often get overwhelmed with that. But what I come across a lot when people talk about hospice, the families always want to know what are going to be the physical experiences that what will my loved one experience physically when they go into hospice. So I wanted to flip it back to Lenita to go into more detail on those physical experiences, and then we'll transition to the next slide.
Thank you, Lakeland. That was great information on the professional caregiver role. There are many physical changes that take place in as the body declines during the dying process, and that begins with regular body functions starting to shut down. The process of decline can vary between rapid and gradual, and depending on the person and their illness. For example, people with illnesses such as congestive heart failure or COPD or Alzheimer's may experience peaks and valleys where they appear very close to death, but then seem to recover, at least for short periods of time. As many terminal diseases progress, activities such as walking, eating, and even breathing become more difficult and eventually very compromised. As you can see outlined on the slide, pain is the major physical symptom seen during this time, followed, of course, by appetite changes, shortness of breath, skin issues, and increasing weakness. All of these tend to increase the pain, and gradually the person will need more assistance, especially with activities of daily living. The longer it takes a disease to progress to the end stage, the greater the physical changes, and the more adjustments may be needed to help that person cope with that process of dying. This entire process is very distressing for both the individual and their family caregiver. It is exceedingly important that we share information with families in order to prepare them for what they can expect on their loved one's final journey. Appetite and food play a part in this physical experience, so let's learn some tips on the next slide that we can share with family caregivers. Nutrition can play an important role in providing comfort in those final weeks and days of an individual's life, but eating and drinking can become more difficult as an individual's illness progresses. Caregivers may need to adapt the diet to ensure that the individual remains comfortable in this. So I want to share some mealtime tips that will make this easier. First, of course, plan small, frequent meals of their favorite foods. Keep portions small with a limited appetite. Huge portions can instantly make it less palatable for them and sour their appetite. Serve beverages between meals rather than with meals. Liquids served with the meals can sometimes make the person feel full very quickly, so serving them outside of the mealtime helps keep them hydrated and yet not filled up. Always create a comfortable environment so the person feels relaxed and not rushed while eating. And of course, we would never want to force the person to eat. And I believe this is one of the hardest things for most families, but forcing someone to eat can cause severe distress, and they may not be able to tolerate some of the foods that you're suggesting to them. For example, many people at the end of life have difficulty with fruits and vegetables, whereas breads and cereals are usually tolerated well. Another great tip is helping them sit upright during and after meals to prevent choking and to promote digestion. I want to take a minute just to talk a little bit about fluids. Drinking fluids, of course, should always be encouraged. That can be clear soups, ginger ale, fruit nectars, and even tea. But some juices, such as citrus juices, may be very difficult for them to digest and can aggravate some of the other symptoms, especially if they have any mouth ulcers. Some people may have difficulty swallowing, and the hospice team can recommend a thickener, which can be added to liquids to create different consistencies. There's 3 main consistencies. They're nectar, honey, or pudding. There's a label on the thickeners, and you would follow those under the guidance of your hospice team to make sure that you got the proper consistency. It's also important to recognize that eating takes a lot of energy. There comes a point when your body starts to conserve the energy, resulting in a decreased appetite and a decreased thirst. Many completely lose that desire for food or fluids. And families need to understand this so they don't get in the habit of trying to force someone to eat or drink. And I want to end with a couple of examples on how you may use these tips. When my best friend was in hospice, it was difficult to get him to eat or drink anything. But we knew that he loved watermelon slushies from Sonic's, so every chance we had, we would go get him one until he got sick of them. It was one of the few things that he would actually take in at the end of his life. And in contrast, when my aunt was reaching the end, she always wanted toast and jelly. She could eat it at every meal. Every time she wanted anything to eat, she loved toast and jelly. But more accurately, she really loved homemade jelly, and it was a comfort food for her that she was still able to tolerate. So on the next slide, we will further discuss some physical symptoms, starting with pain awareness. Most of us understand that people on hospice will experience increasing pain as they approach death. Families generally expect this, but it's important families understand more about how to handle pain as it occurs. Some important tips to convey are that pain is very personal and is very subjective. 2 people experiencing the same type of pain could react very differently and need very different methods to relieve it. always take any statements made about pain from that patient very seriously. Encourage the family to call the hospice company or the doctor if they notice any pain changes. This usually means the pain has become more intense than they previously noted. The family caregiver could gather as much information as possible about the pain throughout their journey, including type, intensity, location. An example would be, was the pain throbbing or was it dull? Is it continuous pain? Does the pain feel like it's deep or does it feel like it's very close to the surface? We talk a lot in these webinars about journals and taking notes. Here is where that can really pay off. Tracking that pain from early on to the end, what it's like from day to day and week to week, can really help the family caregiver notice things and know when to make those phone calls. We always want to encourage the family to have their loved one rate and track that intensity using that scale of 0 to 10, 10 being the worst level of pain imaginable. Hospice companies provide training and education to families on the type of medications, how to administer medications, and a proper pain management schedule. This is one of the most important hospice messages we can convey, ensuring families that team approach and that extra support to know how to handle those management of pain schedules. There are also many alternatives for pain treatment, such as massaging, heat and cold therapy, visualization and music therapies. So also encourage families to understand the options outside of pain management of medication. Remembering that the emotional toll of the end of life can be just as daunting as the physical ramifications. So I want to transition back to Lakeland to explore on the next slide the emotional toll of a person and their family while they're on hospice.
Again, some great information there, Lenita. You're right. The emotional experience going through hospice and palliative care can kind of be a roller coaster. Can stir up a lot of emotions, and people may react differently and uniquely when faced with their own mortality or when they're going through an intense illness or disease. So their feelings may be specific to the stage of life that they're in, their personality, or even their religious beliefs. And other contributing factors might be their personal experience with losing a loved one, or the physical loss of the illness, and even perhaps the loss of dignity and self-reliance. And those that have been ill for many years may react differently than someone who has had a more recent diagnosis or change in their health. So whatever the situation is, we need to help family members understand that their loved one and members of their family might deal with the emotional experience differently. And people who are dying should be given an opportunity to express their feelings, whatever they may be, because it's a part of the grieving process and the process of gaining closure. So we can encourage families to be supportive, allow for open communication, and give their loved one the freedom to express all emotions, including anger, fear, frustration, sadness, joy, and sometimes hopelessness. So let's look at the ways we can support families during the emotional changes on the next slide. One effective way to help families cope with the emotional needs is to be honest. Always be upfront and encourage them to tell the truth. Have them avoid cliches such as everything will work out or you'll be back to your old self in no time. We can also encourage families to have honest conversations and be open to questions from their loved ones, rather than avoiding them or providing an untrue answer. And if the family caregiver doesn't know the answer, that's okay. It's important for those family caregivers to acknowledge the importance of the question and then look to professionals for the answer. To give you an example, if an individual on hospice asks if their illness is terminal, you could respond by saying, "It sounds like you're very concerned about your illness. Let's talk with your doctor who will be able to answer your medical questions. And we'll write down all of your concerns and then ask the doctor when we visit later." Another way you can provide emotional support is to be non-judgmental. As I just talked about, everyone deals with death differently and manages their feelings in different ways. So being non-judgmental means listening with an open mind, and understanding that everyone copes in a different way based on their past experiences and personal beliefs. Next, it's important not to argue. With a person who is in the stage of denial, their denial might be a defense mechanism that enables them to cope. Families must learn not to take this personally. Help families understand that sometimes a loved one may alleviate some of their anger or frustration by directing it at others. And instead of getting defensive, encourage families to better understand the source of the anger and frustration before reacting. It's also important to allow for silence. People often feel the need to fill that idle silence or fill the silence with idle chatter, or sometimes people are made uncomfortable by silence. But instead, we should encourage families to match the behavior. The individual might be tired, exhausted. Lenita talked about how towards the end of life they need to conserve their energy. So sometimes they might not say anything or have the energy to continue a conversation. And sometimes they might be in pain, so having conversation is uncomfortable. So if the person does not respond to your attempts at conversation, that could be a cue that silence is acceptable at that time. And finally, respect the person's personal space. Each individual may feel differently about how close they allow a family caregiver to be during conversation. Some might prefer to be left alone, while others might want to have family members close, hold their hands, have that physical touch. And in a hospice situation, sometimes it's hard to know what to say. So on the next slide, we're going to look at some phrases that may help you when talking with, or may help families when supporting their loved one. When a person is grieving, they may look to others for strength and comfort. And sometimes they might just want to share their feelings. So it's important to allow them this time without judging them. And these phrases can be shared with families and help them respond to their loved one's grief. And I won't read all of them, but you can see that, again, these phrases are validating the person's emotions and feelings and letting them know that the family member is there to support them. Another way to validate the grief is by sharing the stages of grief. So we're going to look at those on the next slide. And these stages of grief came from Dr. Elizabeth Kubler-Ross, and she's a psychiatrist and author of more than 20 books related to death and dying. She's identified 5 general stages of grief, and they're listed there on the slide. And these stages are pretty self-explanatory, but awareness of them can help people understand the emotions that their loved one and their other family members are going through. And Dr. Kubler-Ross also noted that the stages can occur in any order, and they can even overlap. And sometimes they might not experience all 5 stages. People's reactions are as unique as they are, and some of the people's experience, they may vary their reactions, and they might also change day to day. So that's something to be mindful of. And we've talked a little bit already about spirituality and that area of focus in hospice, so we're going to dive a little bit deeper here on the next slide. It's important to understand the difference between spirituality, religion, and faith. And you can see here on the slide how they differ. Spirituality helps people deal with the unknown elements of life and gives purpose. It also helps an individual develop an inner strength that can be used during times of trouble. Spirituality gives feeling of connectedness to a higher being or power, and each person's spirituality is unique. Spiritual wellness is achieved as a person's actions become more consistent with their values and belief system. Religion is often used to describe organized collection of beliefs, cultural systems, and worldviews. And spirituality is not necessarily religion, as some may belong to religion but are not spiritual, and vice versa. And then faith is confidence or trust in a person, thing, deity, or in the doctrines or teachings of a religion or view. And I heard a chaplain say once that whatever brings joy to your life can be a spiritual experience. I thought that was a neat phrase. For example, someone sitting outside listening to music, it might bring the same sense of peace as attending a church service or reading a Bible. So when it comes to the family dynamics and the topic of spirituality, religion and faith can be a sensitive one. I've heard families get into arguments over getting mom to church services versus letting her decide what her wishes are. So for us as professionals, we need to be able to help the families identify the spiritual needs of the person on hospice or on palliative care and how their spiritual needs can be met as they receive services. There's also an exercise families can do that kind of go around this topic of spirituality. So let's look at that on the next slide. And this activity can be considered a spiritual experience. It could also be some sort of a life review or life legacy activity. But a family caregiver may initiate this or be prepared if their loved one brings up this topic. So there's some basic questions listed here. And this might help them reaffirm their meaning behind his or her life. And then they can also ask questions and share these answers with the family. And it can, again, help bring some sense of closure. I learned that if a person can reconcile differences or hard times and feel as though they have had a meaningful life, then the dying process is more peaceful. So this is truly a great activity to do or to encourage families to do. And then a person might also go through the process of relationship completion. So we're going to take a quick look at that on the next slide. And relationship completion comes from Dr. Ira Box, who wrote a book, 4 Things That Matter Most. And there are 4 things that a dying person must do before saying goodbye to their loved one. That's the premise of this book. And those 4 things are ask for forgiveness, offer forgiveness, and that includes forgiving themselves, offer heartfelt thanks, and offer sentiments of love, and then saying goodbye. So these collectively are called relationship completion. So you might hear phrases listed on the slide here, and you might, the family members might be experiencing these types of conversations throughout this process. So I know we're getting close to the top of the hour, and I wanted to pass it to Lenita quickly to talk about the changes in the final hours, because that's another question that family members often ask is what's going to happen at the very end. So if we transition to the next slide, Lenita will talk about that quickly.
Thank you, Lakeland. No matter how much preparation you have, families still struggle as they watch their loved ones through their final hours. Hospice is designed to help support them at this crucial time, but we all must recognize that this struggle is very real. And as someone is reaching the end of their life journey, knowledge of what is about to occur can take away some of the fear and help that family deal with those changes. The main items families notice are changes in breathing, potentially fast breathing one moment to slow to maybe not at all. Along with that, because of the accumulation of saliva and mucus in the throat, breathing may start to sound as though a person is gargling. This noise resembles a rattling or a fluttering and is commonly referred to, especially in clinicians, as the death rattle. The noise is very distressing to families, so preparing them for it takes some of that fear away. Another change is their eyes. They may look glassy, or they may appear that they're crying or tearing or half open. Sometimes that's kind of alarming to the families if they aren't prepared. Their skin develops a very distinctive purple, blue, red pattern as a result of the reduced blood circulation, and that's referred to as mottling, which begins, of course, when the body transfers all their energies to the vital organs. And at the same time, then their pulse will weaken, and it becomes harder to find it. As a person nears death, many times they have an unusual surge of energy. They may want to get out of bed or talk to their loved ones. Sometimes they're clearer than they have been in days. This energy likely will not last long, but it can be a very special time for the family. I know with my family, my mother-in-law had a tremendous surge at the very end of her days, and it became a great time of forgiveness and love and healing for her children. There are additional signs that persons who are dying may show as they near death, and these signs have been documented many times in hospice literature and are fairly common, but not necessarily happen every time. Hospice nurses Maggie Callan and Patricia Kelly, who have reportedly worked with over 2,000 families, coined these as nearing death awareness in their book, The Final Gifts. They recognized signs that death were near, even when the person experiencing them couldn't explain in common terms what was happening. Many times families felt that their loved ones were just delusional at these times, but these nurses had begun to recognize that there seemed to be a special awareness of approaching death. And so sharing that information with that family can really help with that process. So examples of what they identified is increased talking about people who have died in the past, gesturing, which includes smiling at seemingly nothing or reaching for someone or something that you cannot see, dreaming about people, places, and past events. So we should encourage the family to pay close attention to the words being used and what they're saying, because many times the obvious words escape them. And it's important for our families to understand that each person will have a unique passage from this life. One person may slip away quietly, while others may be agitated to the very end. Really, the hospice team's main job is to support all parties on this journey, no matter how unique that passage plays out. We know these family caregivers aren't usually caring for themselves fully, but in a caregiving situation like this, they neglect themselves even more. So I'm going to pass this back to Lakeland to take a look at the ways to better support the family caregivers.
All right, so on this slide about family caregiver self-care, you can see some ways that family caregivers, they might have trouble accepting their feelings, but we need to, as professionals, reassure them that they're not alone in feeling these feelings. It's perfectly normal. And we need to encourage them to cope with this in healthy ways, such as joining support groups, talking to friends, writing letters, making lists, talking, crying, exercising, meditating, yoga. There's so many different ways that family caregivers can make sure they're taking good care of themselves so that they can provide the best care for their loved one during the final days and months. And I wanted to jump to the resource slide here next. And then, Steve, if we can leave that up. I apologize, everyone. We went over time. We don't have a whole lot of time for questions, but if we can leave the resources slide up so people can look at that while we take questions, that would be awesome. Is that okay, Steve?
Yes, that's absolutely fine, Lakeland. Yes, it is time for the Q&A portion, everyone. These resources are on the slide download, that you will receive later on today by the end of the business day, and also posted there in the chat option. So you don't have to write them all down there. You can get them on the slide. PDF will be sent out. Let's get right to it here with the questions here, presenters. The first question, what does it mean that a patient can choose his or her own attending physician?
So the hospice benefit is created so that the hospice physician doesn't take over all of the care, because it seemed to be something that happened in some of the hospices way back in the beginning. They wanted the patient to have the choice to remain with their attending physician with the support of the hospice medical director or physician or not.
Yeah, so it would be like keeping your general practitioner that you've been seeing your whole life, but still using the hospice company, kind of like a partnership. Would that be right, Lenita?
Correct.
Good question.
Okay. I've got a couple similar questions here, which I'm hopefully going to combine as well as I can into one here. The question is about the respite care that you were talking about. You were talking about the 5% cost that families would have to pay, and also the respite benefit. Is it only 5 days a month, or you said it can be more if needed? Can you just clarify and talk about that for a little bit?
Sure. So more than one respite period, but no more than 5 days, is allowable in a single billing period according to the Medicare CMS guidelines, which is in Chapter 11 of the CMS guidelines. So it doesn't specify how many times you can have respite within a 30-day period or a 60-day period. It just says it can only be 5 days each time. And then as far as the 5%, it's kind of, it's not really a copay, but Medicare does make an allowance, just like they do with a lot of their benefits, that you pay a certain percentage of what the charge is. So for respite care, it's 5% of the bill, of the Medicare allowed billed charges.
Okay.
Does that help?
Yeah, I believe so. Next question, can you talk a little bit about patients who are still receiving treatment, for example, chemotherapy, while getting palliative care? What happens in an instance like that?
So palliative care is not considered hospice, so they still are using a lot of curative cares. So your hospice benefit does not kick in during that time because they haven't chosen hospice yet if they're still receiving chemotherapy or radiation or anything that is considered curative.
Okay, and this next one kind of dovetails into this. You were kind of talking about a little bit right now, but can you please explain again in very simple terms difference between palliative and hospice services, just so we're totally clear?
Sure. Palliative care, I think the best way to describe it is supportive care that you can still use in conjunction with curative care. So palliative care can be used along with the treatments that are prolonging life or curing the disease. Hospice does not cover any use of curative care. Once you've chosen hospice, that means that your curative care stops and you go more into support care, how to support you to the end of your life.
All right, very good.
Just to kind of go back to the example that you gave of Fran, she, at the beginning, wanted to treat her cancer and have palliative care. So she was having chemo radiation, but she was also working with a palliative care physician to help reduce the symptoms of the chemo. So maybe it was relieving some of the pain that went along with the chemo, the nausea, that sort of thing. So the pain management while still treating her cancer. But then it came to a point when the cancer was no longer curable, so then she transitioned to hospice. Some people, if their cancer is cured, they would go off of the chemo and radiation, off the palliative care, and back to their normal daily life. So that's kind of where it's, and I hope that might also help in simple terms, explain the difference.
Yes, okay. I think we can squeeze one more quick one in here. Question, how do you know when the right time is to have a loved one go from home health care to hospice? My father was recommended to have home health care hospice and passed away before their second visit.
We see that a lot when hospice is called in too late. When people are on hospice for really only a week at a time, I'm sure, Lenita, you've seen that.
Absolutely.
Lenita, do you have any thoughts on the answer to that question?
I think that it's really, it's a great question because it's a very difficult thing to determine. Many times physicians aren't ready to give up yet, so they don't really drive anybody to hospice until it's almost too late. So I think that for the most part we have to think of it as a family or patient choice when it becomes too much and when it's really at a point where the burdens of curative approach outweigh any benefits. You're not going to get better, and so it's how do you want to live out that remaining time and what kind of quality do you want? Because the longer they stay in curative, the less, unfortunately, the less quality there usually is there.
Okay. Well, we have unfortunately reached the end of our hour here, and we are out of time, so it's time to wrap up. But Lenita Noki and Lakeland Hogan, I want to thank you so much for being here with us today and presenting. Thanks so much.
Thank you.
Thank you.